lesson itself. So today Vakas is taking the lead with a lesson on the access site, the most important access sites used for interventional cardiology, talking about angioplasty, not structural heart disease. Vakas, if I'm not wrong, we excluded structural heart disease.
Yes, sir.
So you will go through the radial and the femoral approaches, which are
yes, sir. Yes,
the
sir.
two mostly used approaches. Actually, there is also the brachial one, who is not being used so much because it's associated with a lot of complications. That said, we have another, another lesson next week. It will be September the 6th, just to conclude this third, I would say, group of lessons. And then we are already preparing other topics, which is IVUS and a clinical appraisal. There have been presented a lot of studies recently on IVUS, so a clinical appraisal on the use of IVUS for angioplasty. And then OCT, again, also Lumion 4 has been presented during European Heart ESC Congress last week, and there are important news about it. And then thrombus aspiration, anatomical variation of coronaries, so an angiographic and also interventional approach, how to face and to manage anatomical variations, and something that is not related to interventional cardiology, but it's more clinical, a review on SGLT2 inhibitors in cardiology, specifically for heart failure patients. So these will be the next lessons, but today, Vakas, you can take the lead and start with your presentation. We will interrupt you in case it's needed, in case we have some specific questions, some comments. And so please, Vakas.
Yes, sir. I'm sharing my screen.
Are you able to share it or you need assistance?
Sir, I'm just able to share my screen. Have you got it?
No.
Host disabled participant screen sharing. Sir, I think my screen has been
Lisa?
disabled.
Yes, Dr. Baker, you can be by your side maybe.
Okay.
But who is the organizer? It's me? Okay. Yeah, great. So try now.
Yes, sir. Have you got it?
Yeah, we can see it. Great.
Yes.
You can put it in presentation mode. Great.
Yes. Thank you.
Very well.
Today, our presentation and topic is differences between the access site. I am Dr. Mohammad Waqas Mazhar from Rawalpindi Institute of Cardiology, Pakistan. Starting from the presentation, I mostly emphasize on the two basic access sites, which are the very common sites, the radial artery and the femoral artery. So starting from the radial artery at its conventional access site has a mean diameter of 2.69 in men and 2.4 millimeter in women. The average range is 1.15 to 3.95 millimeter. The ulnar artery is usually larger than the radial artery. It contributes more blood flow to the palmar arch and can provide a feasible access site in the context of radial artery occlusion. Due to deeper course and the wrist flexor muscles, hemostasis of the ulnar artery can be more difficult to achieve because of difficulty in compressing it against the underlying ulna. Transradial access is associated with a higher rate of access site arterial spasm and thrombosis and occlusion. This is the radial artery anatomy. In the forearm, the radial artery first segment descends along the preaxial border, accompanied by a pair of radial veins called the vena comitans. The radial artery middle segment runs in close proximity to the superficial branch of radial nerve Inferiorly, it runs between the brachioradialis laterally and pronator teres muscle medially. Then passes infralateral between the brachioradialis and flexor carpi radialis to reach the anterior surface of the distal end of the radius, where the radial pulse is felt against the bone. The presence of bone posteriorly should be verified sonographically when choosing the puncture site because it significantly aids in the radial artery puncture as well as manual compression to achieve the patent hemostasis during closure. This is a bit busy slide, but I main focus is on the anatomic snuff box. In the hand, the radial artery segment enters the palm by passing between the two heads of the first dorsal interosseous muscle. What is the anatomic snuff box? It is formed by the abductor pollicis longus and extensor pollicis brevis tendon laterally and the extensor pollicis longus tendon medially. The carpal bones, namely the scaphoid and trapezium, constitute a deep border. It contains the radial artery and vein, cephalic vein, and superficial branches of the radial nerve. These are the anatomical findings of the radial artery, different anatomical aspects of the radial artery and its course. I cannot go into the details because there's a long detail in it. Moving forward, there is a what is the distal transradial access? Distal transradial access involves a puncture within the anatomic snuff box distal to the origin of the superficial palmar arch branch. The risk of the hand ischemia resulting from the radial articulation is substantially low in distal transradial access. Moving on the right side of the screen, as my pointer is there, this is the radial artery and this is the ulnar artery. The radial artery, it is a proximal radial artery and this one is the distal radial artery. The branch, this is the superficial, it supplies the superficial palmar arch of the hand. Superficial palmar arch is a landmark between the proximal radial artery and the distal radial artery. If the radial artery occludes at the distal transradial access puncture site, the superficial palmar branch arising proximally continues to provide the blood supply to the hand. Also compared with the more proximal radial artery, the distal radial artery is more superficial relative to the skin, allowing for more rapid post-operative hemostasis. The puncture site location facilitate access with the disc pronated rather than supinated in the conventional radial artery access, thereby enhancing the patient comfort. So this picture shows that this is the proximal radial access from here, and this one is the anatomical snuff box, and for distal radial access, it is this side from where we'll have a sheath inside the radial artery. Moving forward, what are the basic differences between the distal versus proximal radial access? In terms of success rate, there is no difference between the distal radial access and proximal radial access. In terms of crossover to femoral, there is also no difference. What about the efficiency? Timing to obtain access, both are good, but proximal radial is much better than the distal radial. Difficulty obtaining access, both are equivalent, but proximal is better than the distal radial access. Able to insert the larger sheath, then again proximal radial is better than the distal radial access. Time to hemostasis, there is no difference, and ease to coronary engagement from proximal radial access is better than the distal radial access. What is in terms of comfort? Operator comfort with the right radial, no difference. Operator comfort with the left radial is better with the distal radial access. Patient comfort, right radial and left and the distal radial, no difference. And patient comfort with the left radial better in terms of distal radial access than the proximal radial access. What about complications? Compartment syndrome and hand ischemia. These are the two major complications for the radial access. And in terms of distal radial access, we can prevent a compartment syndrome more when we compare it with the proximal radial access, and in terms of hand ischemia as well. What are different steps of the radial artery cannulation? First of all, palpation of the radial pulse, then steroid preparation draping, ultrasound, obviously, if it is available in the cath lab, local anesthesia, radial artery puncture, and access to the, after getting the needle insertion, we will put a wire inside with 0.018-inch guide wire. then skin nick, skin nick is optional as most some of the Tremor devices, which are the very soft and the sheet go easily with slippage without giving the nick to the skin, but not with the all sheets. Then sheath insertion, sheath aspiration and flushing, and securing the sheath. There are two ways to puncture the radial artery. First is front wall stick. You just penetrate the needle and just push the needle up to the front wall of the needle, up to front wall of the radial artery, and getting the blood, and then you move further. And second access is double wall through and through stick. You can push the needle inside, puncture the radial artery through and through, anterior wall and the posterior wall, and then pull back the needle. And after on pulling back, there is a blood coming out, and then at the same time you can push the wire inside. After getting the sheath insertion, most of we have in practice we are able to inject the vasodilator and anticoagulant. Vasodilator we use in our cath lab are verapamil 2 3 milligram, nitroglycerin 100 to 200 microgram, nicardipine 100 to 200 microgram, and heparin 50 units per kg up to 5,000 units stat. Or some operator like to inject it inside the aortic root rather than in the radial sheath. This cocktail is mainly used to prevent the radial artery spasm, and heparin to prevent the radial artery occlusion. We give the heparin to prevent the radial artery occlusion in the future. What are the different trials? What are different trials? The basic differences between assessor. A meta-analysis was done in 2016 based on 24 trials for acute coronary syndrome patients. Rival trial, Matrix trial, Rifle, STE, ACS, and STEMI radial.
Yeah, Vakas.
Yes, sir.
Now you're talking about the meta-analysis, but so far you have discussed about only radial.
Yes,
so
sir.
Difference between distal and normal radial approach. So first you should discuss about some technical hints about the femoral approach, and then come back to this part. Don't you think?
Sir. So moving forward, sir, and come back.
Yeah, and then you come back. Yeah, it's better.
Yes. Sir, right now the radial is not yet closed. I just want to highlight this as well for radial. The incidence of radial artery occlusion is approximately 1 to 3% due to intima media thickening, which may be a result of acute inflammatory reaction and endothelial dysfunction post-procedure. Most of these occlusions tend to be benign, but can limit future access via the radial approach. It is very clear in the diagram that radial artery friction and spasm. The radial artery, as we know, the basic lumen is 1.8 to 2.5 millimeter, and the femoral artery lumen is 8.5 to 12 millimeter. So whenever we push the 6 French catheter or sheath inside the wall, then there is a definite rubbing of the sheath with the walls of the radial artery, which results in the abrasion of the intima, leading to radial artery spasm or radial artery occlusion in future. So maximum tolerable sheath size or catheter size will be 5 French, 6 French, or nowadays people are using 7 French, 7 French with the slide sheet, which is a 6 in 7 French sheet.
Actually, you can use also 7 French, a true 7 French. In a young male, it's not difficult to use a 7 French with a transradial approach in case it's needed.
Yes, notice. So moving forward towards our femoral access, what are different steps to achieve the femoral access? Number 1, palpation of the femoral pulse, sterile preparation and wrapping, fluoroscopy of the femoral head, ultrasound guidance if available, local anesthesia, femoral artery puncture, 0.1 inch guide wire insertion, fluoroscopy of the guide wire, skin nick, which is optional, insertion of the micropuncture dilator assembly, advance a 0.035 inch wire, fluoroscopy of the 0.035 inch wire, then sheath insertion, sheath aspiration flushing, and femoral angiography. In these, there's a point that this is a 0.18 inch guide wire and 0.035 inch guide wire. So two differences that some people are using micropuncture technique to approach the femoral artery rather than going from the high gauge needle like 18 gauge needle. For micropuncture needle, it is a 21 gauge needle, and 0.18 inch guide wire is compatible with that needle. What are the different landmarks for the femoral access? First of all, you will identify the mid-inguinal point. The mid-inguinal point is a point between the anterior superior iliac spine and the pubic tubercle, and it's thought to simulate the course of inguinal ligament. So this is the anterior superior iliac spine, this is pubic tubercle, and this is an imaginary line, which is just on the top of the inguinal ligament. And your puncture point should be 2 to 3 centimeters below the mid-inguinal point at the level of mid-femoral head into the common femoral artery. High puncture, we define high puncture as if the puncture above the level of the inferior epigastric artery, it is called a high puncture. And any puncture which is at the level of superficial femoral artery or profunda femoral artery is a low puncture. This is the cath image taken from the cardiovascular intervention therapeutics, and it is mostly done in our cath lab on the fluoro guidance. This is a fluoro guidance image, and we divide it into 5 zones. This is the femoral head, zone 1, 2, 3, 4, and 5. And ideal puncture site is puncture the skin at the zone 5 inferior border of the head of the femur. Enter the artery at the midpoint in the zone 3. So this is the zone 3, and this is the midpoint, mid-femoral head, which is 2 to 3 centimeters below the mid-inguinal point. So after this is the artery.
Vakas, can you just enumerate and inform us on which are the main complications of a transfemoral approach according to the puncture site? So if you puncture it too above the correct point, or if you puncture it too below the correct point, which are the types of complications that you may incur?
Yes, sir. Sir, basically, when we call it a high puncture, it is above the level of inferior epigastric artery, and at the level of inferior epigastric or above the inferior epigastric artery, there is a no bony surface underlying. So if we inject our needle, if we puncture our puncture needle if above the that point, then we will call it a high puncture, and for high puncture there is no underlying bone, and it will result in retroperitoneal hematoma because we are not able to compress it. Similarly, if our puncture point is high above at the level of inferior epigastric artery or above, then vascular closure device it is also a contraindication to a vascular closure device as well. So at that, this is a high puncture, and high puncture will lead to retroperitoneal hematoma. What about the low puncture?
Yeah, this is correct. The high puncture can be associated to retroperitoneal hematoma, which is a real emergency in interventional cardiology, and can theoretically, if you don't address it by CT scan, angiography, whatever, very fast, can also lead to the death of the patient. So that's an important complications. And what about the below puncture?
Yes, sir. The below puncture is at a level of superficial femoral artery or profunda femoral artery, and below puncture will lead to below puncture is like from this is the lower head or lower border of the head of the femur. If our puncture is from the lower border of the head of the femur below, then it is a lower puncture, and it will lead to a pseudoaneurysm formation or vascular AV malformation.
Or hematoma, just
or hematoma, femoral hematoma. Yes, sir, femoral hematoma.
All right, thanks.
Moving forward, these are the main branches. This is the 2 to 3 centimeter portion, which is a common femoral artery, and above it is the external iliac artery, Before external iliac artery, there is the inferior epigastric artery, and these are two bifurcation points. These are profunda femoris and the superficial femoral artery. Moving forward to our next slide, this is the ultrasound guidance puncture. And on ultrasound, if we are having below bifurcation, this is the two branches. These are the two branches: superficial femoral, profunda femoris, and superficial femoral artery. And there is a vein. And above bifurcation, this is a common femoral artery, and this is a common femoral vein. This is a small short video. I just I think it is not playing. Just a minute.
No, it seems just a picture, not a video.
I have recorded a video, sir. I think just a minute. I can just. I think yes, it's a picture format. Sorry.
Yeah.
I have recorded a video with my mobile and has pasted.
Okay. Okay, no problem.
Moving forward. Now, what are our goals of the femoral puncture? As you see that these are two branches. Our sheath insertion point is above the level of bifurcation at the level of mid-femoral head. It is very clearly seen in this picture. And while the wire is inside, you can see the wire is inside and our sheath has been done. Then we take a simultaneous injection of the common femoral artery in the aerial view to look for any false passage of the wire or any hematoma starting after the sheath insertion. And at the end of the procedure, you can see that there is a collection of the dye within the urinary bladder, but there is no indentation of the bladder. So in our practice, in our cath lab, we are after doing PCI, we are very much with the femoral approach. We are very much in habit of taking the last final cine view of the pelvis to look for the bladder indentation sign. And with this, in the start of the procedure, after getting the sheath insertion, we mostly do the peripheral angiogram in the area view to look for any false passage of the wire or any hematoma start from the beginning.
Yeah. So if you have a complication, it is important to understand it clearly. The sooner the better.
Yes.
Which is the penetration of? Can I ask all of the other guys to mute themselves, please? So, which is the penetration of the radial approach in your cath lab and in Pakistan overall? How many?
Sir,
what percentage?
Sir, mostly in my setup, it is a high volume center, and we are 90% with the radial. But right radial, if right radial is not feasible, then we will switch to the left radial. If we are not able to go with the left, then we'll switch to the femoral approach. Femoral approach is our last approach.
And in Pakistan, it's still 90% or it's lower?
Sir, it is we have 5 high volume interventional cardiology centers in Pakistan, and out of these 5, all have a radial approach by default.
Okay, so it's quite common to use.
Yes, sir.
The radial approach as a default.
Yes, sir. We use the femoral approach whenever we are doing the acute stroke intervention in our cath labs. We have 2 cath labs which are dedicated stroke intervention cath labs. Yeah,
but that's a different animal.
Yes, sir. Yes, sir.
An important point, an important suggestion is to use always keep in each cath lab an echo Doppler, a duplex scan, in order to facilitate the femoral approach with it. This has been shown to reduce the vascular complications associated with a femoral approach. So this is a good suggestion, just to keep an echo there and to puncture all of the femoral arteries under echo guidance.
Okay, yes, sir. Echo guidance, yes. Moving forward,
please go ahead.
Yes, thank you. Moving forward, what are the basic differences in terms of radial and femoral access? Radial access is difficult, while femoral access is easy, as it is a larger diameter vessel. Diameter of the radial artery is 2.5 millimeter, and every diameter of femoral artery is 10 millimeter. Access site complications are negligible with the radial artery, but it is significant with the femoral artery. Hemostasis is easy with the radial artery and difficult with the femoral artery. Post-procedure ambulation is immediate with the radial artery, while it is delayed in femoral artery. May we discuss, sir, these trials, or we will go in the end, sir? I have still 2-3 slides more for the femoral artery. Are you getting me, sir?
Excuse me? No, I didn't get your question. Sorry.
Sir, may I proceed forward or with the
Yeah,
trials,
please.
or?
So now let's see. There, not very recently, but until a few years ago, there have been a lot of clinical trials addressing the characteristics and the clinical outcome associated with the transradial and transfemoral approach. With our center, we have participated to two of these trials. I was country PI for Matrix, and I participated to Rival. These are important pivotal trials on the correct the vascular approach for normal or for emergent PCI. And after these trials, the transradial approach totally changed the scenario, because when I started this job 15 or a little bit more years ago, the transfemoral approach was the first one, and the transradial was reserved only for diagnostic cases or simple cases. Now, as you said, also in Pakistan, and I would say all over the world, the transradial approach is the first one. And then if you don't have a good transradial approach, then you convert your PCI to a transfemoral one. So now let's see which are the trials that have changed this scenario.
First of all, sir, Rival trial, it is a multi-center trial which was conducted in 32 countries with 1:1 randomization, and which is an open label trial. And its population is 7,021 patients with acute coronary syndrome. Primary endpoint rate, which is comparison of transradial access with a transfemoral access. It is in terms of composite of death, MI, stroke, and non-cabbage bleeding, 30 days, which is 3.7% with the transradial versus 4% with the transfemoral approach, and p-value is 0.50. All-cause mortality at 30 days is 1.3% versus 1.5% with a p-value of 0.47.
So, which is the message of the Rival trial?
Sir,
in 2 words.
Sir, transradial approach is far better than the transfemoral approach in terms of
actually it is similar for ischemic endpoints and hard clinical endpoints like all-cause mortality, but is associated with lower bleeding. So this is the main message of Rival.
Lower bleeding.
Yeah.
With the lower bleeding with the radial approach as compared to the transfemoral approach.
Yeah.
And so next, Rival STEMI, which is a subgroup analysis, which was conducted in 2012. It is also a multi-center and open label trial conducted in 32 countries with 1:1 randomization. And in this 1,958 patients with STEMI, and in terms of primary endpoint and composite of death, MI and stroke, non-cabbage bleeding, 30 days, 3.1% with the transradial approach and 5.2% with the transfemoral approach. And similarly, in terms of all-cause mortality at 30 days, it is 1.26% with versus 3.19%. Sir, this is a sub-study, and it also shows a significant difference between the transradial and transfemoral in terms of bleeding complication. Next, Rifle STE ACS, it was conducted in 2012. Most in the multi-center European centers, and it is also open label trial with 1:1 randomization, and 1,001 patients were included with STEMI. And what are the primary, and in terms of primary endpoint, composite of death, recurrent MI, stroke, target lesion revascularization, or non-cabbage bleeding at 30 days is 13.6% with transradial and 21% with the transfemoral approach. So all-cause mortality at 30 days is 5.2% with the transradial and 9.2% with the transfemoral approach. STEMI Radial, which was conducted in 2014, it is a multi-center national Canada. It was done in Canada, I think, and it has randomized up to 707 patients with STEMI, and the primary endpoint in terms of composite of major bleeding and vascular complications was 1.4% with transradial and 7.2% with the transfemoral approach. And all-cause mortality at 30 days is 2.3% versus 3.1%. And later on, Matrix, which was conducted in 2015, and it was done in multiple centers in the Europe with 1:1 randomization. It is also open label trial. And in this, about very large patients were taken, which were 8,400.
Please mute yourself.
8,400. Yes, sir. 8,404 patients with acute coronary syndrome, and the co-primary composite endpoints of death, MI, stroke were 8.8% with transradial and 10.3% with the transfemoral approach. And
here, for the first time, there was a reduction, probably related to the higher population enrolled of ischemic also endpoints, not only bleeding endpoints. So the balance between transradial and transfemoral was broken not only by a higher occurrence of bleedings in the transfemoral approach, but also in this case with more events, type of ischemic events.
Ischemic events in terms of radial artery occlusion?
No. Death, MI, or stroke, as you said.
MI and stroke, yes, sir.
Yeah, there is a significant difference, but there is also a significant difference in all-cause mortality, which is, an important information.
Yes. And similarly, all-cause mortality at 30 days are 1.6% with the transradial and 2.2% with the transfemoral approach.
Yeah.
There is a false study for ultrasound-guided femoral access. It showed that ultrasound-guided common femoral artery cannulation rates did not differ from the traditional approach rates except in patients with high bifurcations. Ultrasound guidance,
this is, this study is not. So the problem here is not related to if I use ultrasound or not. Okay, if there is a center that uses a lot of transfemoral approach, probably you don't need to do ultrasound in all of the cases, but only in selected cases. The problem now is that in the world, not only in Europe, but now also in the world, in the vast majority of centers, there is a transradial approach in more than 90% of the cases. And then this means that the physicians are not experienced with a transfemoral approach. You have young physicians that come and do their first 100 PCI with a transradial approach. So they cannot manage a transfemoral approach. So this is why it is very important to understand the study when you present it. This study has been performed in centers that had a huge experience with the transfemoral approach. In these cases, again, I repeat, you don't need to have a routine ultrasound approach, but in the normal centers, so you should use it.
Especially when, sir, especially when there is a when in the high volume centers, if we have started our we try to change our practice on ultrasound guided femoral access, but we were quite not comfortable with this approach, to be very practical, as most of the time initially when we started we were not able to appreciate exact common femoral artery where to hit.
You need to have some experience with it, but truly, if you have if you don't have to look after the machine, because where is the machine? Let me go and seek it. Let me find where is the probe. So in this case, it's a waste of time. But if you have the machine in the cath lab, the ultrasound machine, then you take it. You should use it just for 20 seconds, 15 seconds. in a normal case, not in a complex one, are enough just to see where is the vein, where is the artery, and at which level you have the bifurcation. So this is the information that you should use. A third important information is if there is a calcification, because you should avoid the puncturing where you have the calcification, but because if you have a calcification there, you probably will have some hemorrhagic complication. So with these three information, which are, I repeat, very fast in a normal case, it's easy to implement the ultrasound in your cath lab. So try again. Maybe you can ask for some help by your vascular surgeon or from your radiologist that can join you the first times for a few cases, and then you will be independent. It's easy. You don't need to do a complete ultrasound to your patient, of course. You only have to focalize on a common femoral artery and just to see these couple of things.
Yes, sir. Notice, sir. So ultrasound guided guidance also resulted in improved first pass success rate, reduced number of attempts, reduced risk of venipuncture, reduced median time to access, and beneficial in patients with peripheral arterial disease, obesity, especially scarring and fibrosis from frequent previous access. So in a brief summary, comparison of femoral and radial artery access for cardiac catheterization, excess size bleeding, it is 3 to 4% with the femoral artery, then 0 to 0.6% with the radial artery. Arterial complications like pseudoaneurysm, retroperitoneal hematoma more with the femoral artery, rare local atiovenous fistula, painful hematoma irritation, pulse loss 3 to 9% of cases. Patient comfort level, it is acceptable, but with radial it is very good and great. And ambulation, it is 2 to 4 hours after the femoral artery, and it is immediate after the radial artery access. Extra cost, Cloyer device, obviously you need to have the Cloyer device to close the femoral puncture. And in terms of radial artery, it is a band occlusion. Procedure time perceived shorter, and in terms of radial artery, it is perceived to be a longer, especially when especially sometimes after injecting the local anesthesia, we feel that there is a spasm of the radial artery, and radial artery went away immediately, especially after the local anesthesia. Estimated radiation exposure perceived shorter, and in radial artery it is perceived longer. Access to left internal memory artery, it is easy with the femoral approach, and it is difficult from the right radial artery.
Yeah.
Use of artery for cabbage, not known, and use of radial arteries for the cabbage, it is quite unknown. And the learning curve is short with the femoral, and it is longer with the radial artery access. More than 8 French guide catheters femoral can accommodate. But
no problem. I don't know. Yes, a femoral can accommodate it, but it's
yes, sir.
There is a clear correlation between the size of the guiding catheter and the sheath and the risk of complications.
Yes, sir. And with the radial artery, maximum you can use up to 7 French in men, as Professor mentioned before. Peripheral vascular disease problematic with the femoral, and no problem with the radial access. So in conclusion, the femoral and radial accesses are 2 equally valid options. Operator experience is the deciding factor for choosing one approach to other. However, radial learning curve is steeper. Bleeding complications are lower with the transradial access. Radial access in patients with STEMI is associated with significant clinical benefits in terms of both lower morbidity and cardiac mortality. Thus, it should become the recommended approach in these patients, provided adequate operator and center expertise is present.
All right. Thank you, Vakas. You did a comprehensive lesson on the transradial and transfemoral. Of course, we could speak for hours about these 2 approaches, which have clearly shown also in the TAVI era how important is to warrant a non-complicated approach. We have seen from the TAVI spread 10 years ago or a little bit more, that the first cause for mortality after TAVI was the approach, because we learned with these valves how to perfectly implant them, and patients didn't die for in the vast majority of the cases for the TAVI implantation, but for the approach, because we were not prepared to face and to treat the complications with a femoral approach. And then this changed the scenario and the approach to the approach. Now in many centers for TAVI, for example, there are two contemporary approach with a wire protection put from the left. For example, if you have the right femoral approach as a first approach, as the main approach, you can put a wire from the left to protect it, and in case you have a complication, you inflate a balloon very fast and you can work easily on the complication. So as I said, we could speak for hours about this, but I think that your presentation was complete, and we tried to cover all of the main areas. I would like to have some hints and comments by the team, either from the CRO or from the DCB Academy. Please go ahead. Vakas is ready to reply to all of your difficult questions. Please. Comments, criticism. Say something.
Excuse me, I have a question.
Please.
My question is regarding...
Speaking.
I'm sorry.
Sarah, hi, Sarah. Sorry, I cannot see you. So, Vakas, can you remove the share, please?
Yes, sir.
All right, thanks.
Yes.
So my question is regarding distal and proximal radial artery access. As you have shown, the proximal access was better than distal in terms of obtaining the access site, but not in terms of patient comfort. So in general, which one of the access sites is more commonly used, and would you suggest?
Actually, in the practically when we are working in the cath lab, we especially during the primary procedures and in the elective procedures, we want to be a very quick way. We want to proceed in a very quick way. The only thing we feel the difference is that while using the distal radial and the proximal radial, in terms of distal radial access, we feel difficulty in catheter manipulation, especially when we are going to engage the difficult right coronary artery, aberrant origin. So in that cases, catheter manipulation is a bit difficult, and obviously our procedure time will go high. And especially when we're doing the coronary angiography, we are doing a shorter procedures. As procedure time will go high, then it will lead to radial artery spasm and patient discomfort. But at the same time, in terms of compartment syndrome or hematoma formation, this proximal radial access is having comparatively having inferior results with the distal radial access, because for distal radial access there is a less hematoma formation and compression is very easy. And yes,
yeah, but I have to say that clinically, a clinically relevant hematoma in the radial artery leading to the compartment syndrome is quite rare. I don't know how many cases you have had. If I remember well, in my case history, I had two cases of compartment syndromes, and I did my first transradial approach should be 2003, so 20 years ago. So that's not really an issue. You can have some hematomas, which is usually related not to the puncture itself, but to the management of the bandage or to the tear band or whatever you use to close the hole, but not related. It's not related to the puncture itself, like it is in many cases for the transfemoral. So, in my opinion, the compartment syndrome is not an issue for a normal transradial approach.
yes.
But as you said, the proximal is faster, is also for the patient. I think there is no differences in terms of comfort. You can puncture it in 3 seconds, so I have to admit that I don't like the distal approach, but it's only my opinion. It's not the truth. It's only my opinion.
Yes, sir, I agreed with you because we started the distal radial access, but still we were not comfortable with that, so we left it and switched to our proximal access.
Yeah.
Perfect. Thank you very much. I got my answer.
Great. Jacinth, did you
Hello.
did you
So
listen
yes,
to the lesson? Yes, it
yes.
is something that is, maybe for you it's not very appealing, but I
Well,
hope that
no, actually, no, not at all, because I'm currently undergoing rotations at the hospital, and I'm on, I'm witnessing a lot of colo, so it's not really new to me. And I wanted to say that, as a non-physician, it was very comprehensive. So the point was, I used to get to the point very easily. And I do have two questions actually, if it's possible.
please. Yes, of course.
Okay, so first of all, I wanted to ask, so since transradial and transfemoral are basically at the end, we can say that they're all equally, how to say, valid. If we want to talk about as a conclusion, can we say that it really depends upon the expertise of the physician and the criteria of the patient we are dealing with? Because there are patients, for example, that might be old. There are patients that sometimes we cannot feel the pulse in the radial, etc. I don't know if I explicitly said the question.
Yeah.
Vakas, you want to reply or please?
Yes, sir. Conventionally, when we started the cath lab in the early or in the mid-20s, when I started the cath lab, our mostly consultants and our senior guys, they were very expert with the femoral approach. They always use a femoral approach as a default approach. Later on, in 2020, there is a revolution in our cath labs, and since 2020, we are using the transradial access, and we are now very much comfortable with the transradial. But if we feel difficulty in transradial, then we'll switch to transfemoral. But because we have a low volume for transfemoral, so obviously it is not in our daily routine practice. Number one. And secondly, you have mentioned that in older patients, there is a no radial pulse due to, yes, you're right, due to atherosclerotic disease, or there's a no radial pulse. Then at the same time, as I mentioned above, that there is a ulnar artery, and which is larger in diameter to that radial artery. But our seniors and mostly data is against that. Don't use the ulnar approach. If the radial artery is absent, you should try to switch to the opposite radial artery, or if opposite radial artery is not present, then switch to the femoral approach. So these are our basic access.
Yeah,
Okay.
the ulnar artery is should be reserved as a very last approach, also because there is no bone behind, and so the big advantage of a transradial approach is that you have the radial bone behind, and you can easily compress it without complications. With the ulnar,
Yes.
it is more complex because the ulnar bone is much deeper, so it is more difficult to compress. Number one. Number two is that there is also anatomically a very quite high proximity with the ulnar nerve. So theoretically, but they have been described, you can have also some neurological complications in case you have an hematoma with the ulnar approach. Ulnar approach is, is not used quite often. Also in our practice, as Vakas said, we try with the right, then if not with the left radial, and then if not, we try with the femoral, of course. Another advantage of the transradial approach is that the part of the artery that you can puncture is quite long. It's not like the femoral where you should be very precise just above the bifurcation. You can puncture it from the normal side up to, I would say, 10 or maybe even more centimeters going versus the brachial artery, because the passage of the artery is just above the bone, and so you can compress it also at that stage.
Okay, I understand. Thank you both. Thank you so much. I do have one more question if it's possible.
Yes.
Okay, I did read somewhere that after transradial access, there is a risk, a 5% risk actually of losing the pulse. Is this correct? And if it is it the same with the femoral access?
Bacchus,
Yes,
please.
sir. As we mentioned that the radial artery diameter is lower than the femoral artery diameter. Radial artery diameter, every diameter is 2 millimeter or up to 2.5 millimeter. So it can accommodate maximum up to 7 French sheath or catheters, as mentioned by Professor Cortese. So there is abrasion of the sheath with the intimal wall of the radial artery, which will lead to the abrasion of the intimal wall and lead to the radial artery spasm during the procedure and radial artery occlusion after the procedure. So this is very right that there is a risk of radial artery occlusion, but to prevent this, we are using a cocktail of nitroglycerin, nicardipine, after getting the getting the sheath inside, then we inject these vasodilators to prevent these abrasion from the wall sheath from the wall of the radial artery. And secondly, we are giving heparin up to 5,000 units stat to prevent the radial artery occlusion, to prevent the thrombus formation after getting the access.
Okay, thank you so much.
Thank you.
Hello.
Hello?
Dr. Walker.
Hello.
Hello.
Yes,
Who is
yes,
speaking?
doctor.
Who is speaking? Antoine?
Hi, sir. Dr. Amit this side. I just want to ask one question.
Yes, please.
Sir, instead of radial approach, if we are not getting a puncture through radial artery, can we use that brachial access, brachial artery puncture, sir?
Personally, I don't like it because for the same reason of the ulnar, it is very difficult. It is truly difficult to compress the brachial artery, and
Yes,
it is an end course artery, which means that if you stop the flow there because you have a thrombus, or if you have to compress it for a lot of time, you may have hand ischemia. Whereas if you have a diseased ulnar artery with all of the collateral flows, even if you occlude for 3 hours the radial artery, you will never have an hand ischemia. So for these two reasons, I would say that I would avoid, unless it's the last remaining access, the ulnar. Femoral artery is much better than brachial artery.
Yes, sir.
Thank you, sir. Thank you so much.
Any other question?
Sir, I just want to ask you one more question, sir. You have mentioned that while using the transfemoral approach for TAVI, you said that you are taking the wire from the contralateral side and place the wire on the ipsilateral side. This is to prevent the complication, or this is to also guide the anterior wall puncture of the common femoral artery from the ipsilateral side?
It's the first one. I mean, as I said, now we are using the echo for all of the punctures, mostly if we are using large bores, 16 or 18 French, or 14 or 16 or 18 French, like for TAVI. So we don't need the angiography and a wire to puncture the femoral artery. We keep the wire there, but I have to say that now we are stopping using this approach. We started using it 10 years ago, just to prevent and to treat, not to prevent, to treat any complication when you have finished the TAVI. We have published an interesting study. I don't remember the name of the study. No, there wasn't the name. It was a multi-center study. I can give it to you if you want by email.
Yes.
It was published in 2015 or 16, where we wanted to address the secondary the fate of the secondary approach in TAVI and in structural heart disease management. And what we understood was that everybody was dealing with the main approach, okay, with a big, large bore approach, and everybody was forgetting the secondary approach, the secondary femoral. For example, if you use the 7 French. So in this study, we clearly showed that there were more complications in the secondary approach, which was used to prevent complications in the primary approach than in the primary approach itself. So this is, you know, so this, what does it mean? It means that you should use, you should be a little bit minimalistic when you do this type of interventions, especially in such sick patients like those that usually undergo TAVI, which can be 80, 85, 75 or whatever. So also the secondary approach should be dealt with a lot of caution and under fluoroscopy, under echo guidance during the puncture.
What is, sir? Yes.
Okay, so if there are no other questions, I think that we can close this lesson. Thank you for your presence. I'll see you in the next Wednesday. All right, which is Lisa, which is the name of the title of the lesson? I don't remember now. Or if anybody else can remember. Yes, can remember it.
Yeah, it's by me, Dr. Cortes. I will be presenting on calcium modification strategies.
Oh, there. That's a huge topic. So we will have a lot to comment and to discuss. So calcium management and calcium modification approaches in interventional cardiology. Great topic, also that one. Thank you.
Yeah, nice topic. Yeah, looking forward. Thank you.
Yeah. Okay. Good evening to everybody.
Thank you all. Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Thank you. Bye.
Bye-bye.
Bye-bye.